The reason Lisa's trachea queen is that when she started in this post, there was suddenly every trachea vented child from Belfast was coming to A2 or Causeway. So
I think they all are in this area. But it's calling in bed and I'm just
yeah, we cover such a big East Antrim particularly is bad. Carrick, for example, that's Lauren. And then because they never had tracking page, they never had a tracking event, and then we really started us then. We've got another one at the minute. She's actually great.
yeah,
She actually went off on the ward before she went.
she had a 1 millimeter trachea and was sitting in ICU for about a month. And no one
Put her on her board to see if she was 12 and 18 and she was admin.
yeah.
Oh, her CFP help me take their route off.
And we came together to transfer and she was unintubatable.
She's all injuries. Laura on the side is kind of, I can't remember the girl's name, but she's really good. She's got really nervous. And
And she was, yeah.
she's like, I'm not keeping her. And I was like, please don't do it. And we'll bring her to see her. So we'll bring her on her phone. And I was like, we'll bring her on because that's really dangerous. He was like, I'm taking the risk, we're going, but we're not keeping her for we know the team. It's quite a sentence hospital. But we're lucky they didn't, wasn't it?
Yeah. I mean, it was a blind illustration, and then they, because nobody could see what our actual tree ever looked like, but then when they went to it was 1 millimeter, and then they had a like dilation. So we went through that, I dilated up to get a 3.5, and
Yeah. We should have 3 in the
she did 3 initially, and then they switched to 3. They had to do dilation to get up to that point, but she was chilling great, just like on nasal split, even after she got it.
I'm sure she was home on these up. Like she was home on oxygen before, and then she came back in on well. Like so she's doing great. Have you seen her before?
I thought she died. Like,
She's driving. You want to see his face?
I went to say I couldn't believe that she was here.
Start days and nights mixed up, so the girls are demented. And there's like one of them.
She was always like that. Like that's.
Oh no, she goes home. Mummy's had her home a couple of nights and she slept all night. And we were like, I don't know how.
It's just
Yeah, any wonder. So again, anybody that's doing pizza that has experience with trachees, just go to the bathroom or something. Warning, whoever else has been. Anybody who hasn't had a trachea before, that we just do it basically. We've modified it slightly because most of our job is training the band 3s, because as you know, most of the children do end up at home on long-term ventilation, who are cared for by their families and by non-registrant nurses, because we don't have enough nursing staff to look after them. Respiratory kindly tell whether they're one-to-one direct supervision, and that does change kind of depending on the one that's currently on A2 is not ventilator dependent, and she does get ventilation overnight, so she's not one-to-one officially where you can't leave them, but she does have a trachea, and her, as we just heard, her airway is very, very difficult. So if her trachea came out and there was issues, that would be a bit of it to do. So lots of different reasons why, but we'll go through it basically. If anybody feels strongly that they've already, has anybody done respiratory? Anybody that's been in children's a lot? No. All of them slagging off their respiratory team, will not be sensitive. One of the last inductions, there was an ENT. Somebody had been an ENT for a year or two, then changed the GP, and I said, you can leave. And he says, actually, I put them in a theatre, but I never change them or do anything afterwards. So I suppose on the ward, and the plan, the escalation plan is always to get you. So you're going to come in if it's a difficult change or something has happened, or if it's fallen out, or if it's blocked. So we just go through a bit of basic kind of, everybody knows what a trachea is, done surgically. It can be temporary or permanent, and a lot of our children do have just those congenital abnormalities. There's a couple with Beckwiths and stuff that have trachees, and they would hope in the longer term when they get surgery that they would be removed. But a lot of them do seem to have them in for a very long time. What's the most common reason why small children need trachees? Is anybody going to guess? We are finding now, although they probably do have an underlying congenital abnormality, it's for long-term ventilation. I mean, most of the ones in the community that are doing well, that are thriving, and there is one wee boy from Lawrence, sorry, apologies for Lawrence people. He's 14 and he's been home ventilated for a long time, and he is relatively well. You could argue that his mommy doesn't think he's well, but ventilation is a big issue, and that has really impacted children's nursing. It's right in community. That's a big portion of the community children's workload, is looking after those children that require ventilation. In the first instance, and certainly in neonatal and stuff, it would obviously be their congenital abnormalities, which sometimes they grow out, sometimes they don't. There were the other group of children then who develop a dependency later on in life, and they're the children. We did have one recently over the last couple of years who used to come in night to A2, and I think his diagnosis, did he have SMA or Duchenne's? Can't remember. But they thought he needed BiPAP at night and he just wouldn't tolerate the mask. So they were talking about tracking him, and you thought, that's a lot just because he was a teenager and didn't want it. But he was really sick and he used to retain the CO2, which is things we would never really have seen in peds routinely, but we are seeing children surviving for longer, I suppose, which is good, but they are developing kind of adult-ish problems around. I remember the day his CO2 was 16, I was like, get the oxygen off. I'm like, well, why? And Mummy was like, he's not really breathing very well, but he needed psychology to kind of, so he did eventually tolerate his math and didn't need a trachea, thank goodness, because he would have been a nightmare. That's just what we use as nurses for our evidence, and that if anybody's got any interest in tracheostomy care, that we book, which is really old, from the National Trachea Safety Project. They have loads of videos as well, and they have a section on peds and adults as well. It is quite good. And that little space at the bottom underneath this one will soon be populated by our Northern Trust trachea policy, if it ever take about 5 years to write it. So there is guidelines, and they are kind of around basic care if anybody wanted to read it, but that's going through the policy at the minute. That's what the trachea generally looks like, and they breathe in and out, although some children, if you ever looked at after seen anybody with a trachea, they do have that ability to breathe past it and talk. And did anybody meet Benji? Benji Castle-Mason? He learned to speak, so before he was 1, he could speak. He was great. He's our trachea poster boy. He was great. And he has thrived, obviously, but he could make noise. Some of them not. Alex starting to learn a little bit about noise, but not. A little bit, but not in comparison to what Benji was doing. That she was maybe sicker than he was. But so some of them can talk past it. Some of the older children have speaking valves. Some of them put their fingers in it to speak. But it is skill, and it does take. So children may be crying and you might not know because you might not hear anything. I just included this one because the middle picture, I would have said confidently a couple of years ago that nobody. Does anybody know what that is? First of all, just being really patronizing. In the middle picture, it's a cuffed trachea. Yeah, so I would have said confidently nobody outside of PICU, certainly nobody on any of the DGHs would have had a cuffed trachea, and certainly nobody at home, but respiratory put a cuffed trachea in a small child and sent them home with a very minimal package. To be fair, she only had band 3 carers going in. So why would you think you would need a cuffed trachea in the longer term? And I know in ICU, if you need a really high pressure ventilation, you would have a cuffed ET tube or trachea, but she needed it because she aspirated all the time. Isla Morgan's, I might have looked after her in the Royal. Yeah. But miraculously, we were really cross at the Royal. Well, they didn't tell anybody, to be fair, and you can't really delegate management of a cuffed trachea at home to a band 3. So there was a lot of training around that. But she had multiple aspiration pneumonias requiring intensive care and admissions to children's. She hasn't had any from she had her cuffed trachea. So we kind of had to bring your toys back into the pram again and say, well, it's actually worked for her. And
no, those they need to take the cuff down.
So a band 3 can't, like if they're sitting with her, they can't deflate a cuff and reinflate it because you have to assess. So they couldn't do that. So they were in the house and they said to Mummy, what's that lead coming out for her trachea? And she was sitting pulling it as well. She regularly takes that wee tube off, which you think would be impossible, but she does pull it. So there is just a lot of training. Her mummy is just so easy going. She just gets on with it. There's no question. She deflates it herself. She simulates. So you're meant to do suction, either deep nasopharyngeal suction or suction through the trachea when you're deflating the cuff to pick up any secretions that have pulled. So mummy does that on her own. I don't know how she does because you would actually need 3 people to do it. Somebody's deflating, somebody's sucking, and somebody's stabilizing. But she's been fine from it. There is an issue long term for her that she will have some sort of pressure in her trachea or necrosis, or so that's in the longer term. It's not ideal, but she's been in nursery for a year and she's going to P1 now, so with her cuffed trachea. So I would have said confidently never, and I probably would never have seen anybody outside of ICU with a cuffed trachea, but she has, and you can see the argument for it. The principles are the same, the general trachea principles, apart from obviously it's got a cuff. There's a lot of issues around deflating and reinflating, and if you overinflate it, you can cause a lot of damage. But unless she came in very sick, and she does tend to just go to the Royal, we shouldn't really see her. But if you see anybody with a wee tube hanging out of it, similar to a catheter, that's just how you inflate it in the valve, you let it down. Her secretions were very problematic, and it has really worked. So the 2 main types of tracheas we would see in Northern Trust, I don't think there's anybody from, sometimes in adults, they have those nice little metal ones that sit really flush with their thing. We tend not to have those. Some of the older children used to have. We used to have one wee boy with a metal one, but most of them are Shileys and Bavonas. Anybody had any experience with either of them? Or- Yeah, so this, well, no, I'm putting you under pressure. That thing that's circled, do you know what that is? Looks like a tooth. So it comes with every Bavona trachea. Mostly the Bavonas are used for long-term ventilation children, and they have this, what's called a flex end, that little longer bit on the external part of the trachea, which means they're generally going to be on ventilation. Some of the children have it because they have a very short neck, and you just need that wee bit of extra space. But that little way, it looks like a tooth. It's if you have your anesthetic circuit on your trachea and it's stuck, but I'll show you it, and it gets stuck with secretions and you can't get it disconnected, which does happen a lot. And you don't want to be, you just flick it in. It's really good. And everybody with a Bavona has one of those, and they should be either in their emergency box or in around their cots. And it's really good because sometimes if they need suction, the nurses might call you and say, we can't get this off because it's stuck. Some of the secretions, as you know, can be really thick and really kind of like super glue-ish. So people just didn't know what that was, and anybody that I've asked hasn't known. So Bavona don't really publicise it very well. Yeah. Well, even so, you would have had for our cot the whole one. Comes in then with a little tie, and they normally tie it to their cot or have it hanging somewhere obvious. But everybody who has a Bavona will have a Shiley as an emergency size down trachea as well, and that will be in their wee trachea suitcase that stays with them at all times. So you kind of need to know the differences between the two for that reason, because if there was an emergency and you had to size down, you would be putting a Shiley in instead. Generally, the Bavona flex ends, Respiratory and the Royal seem to love those at the minute. Everybody, I would say majority. What is that wee? Does he have a Bavona flex? Oh yeah, here you go. The one from Causeway had one as well. So they're generally longer, just if you have a small chin or if you're on ventilation, it gives you that little bit of extra kind of, if you're pulling it and you're not kind of going to dislodge it, gives you that little bit more flexibility. If you're suctioning it, it is longer, so you have to know the suction length for the Bavona. And randomly, which infection control don't really like, as I'm sure you can imagine, they're reused. They're single patient use, but they can be used up to 5 times. So the parents sterilise those and reuse them. So if you were ever changing one in an emergency, it's disgusting, and I don't. And they get like a little brush, you know, if anybody's ever got one cup to put, not toothbrush, you know, like the wee tiny ones you get for your clean out your cup, not a toilet brush, Warren. Put a wee tiny one. It's really like an eyelash thing. You put it in to clean it out. And just last weekend, Ali on the ward, her trachea blocked, and they took it out, and it was crusted inside it. So up to 5 times. So as you know, nurses we could never say your that trachea you have in, that's been washed 3 times. One in the box been washed twice. We just let the parents do that. We don't sterilise them in the hospitals because there's nowhere that you can put respiratory secretions in to a sterilizer where you're sterilising other people's bottles. So just be mindful if you ever were involved in an emergency trachea that they will want to keep that. And they can, if the children tolerate it and they don't have a lot of secretions, it can be changed monthly, which was great for those long-term ventilated children, because before the Shileys were weekly. So you can go a whole month if you don't block it with your secretions or have an issue with it. And that has really improved the quality of life, I suppose, a lot of the children. But then you're putting one in that's now been sterilised 4 times, which doesn't really make sense. There is metal within the Bavonas as well, and they're kind of coy, so they're not MRI compatible. So that's well. So you would have to change to a Shiley, but hopefully nobody will be MRI'd here. Hopefully that would be a Belfast problem, not us problem. Shileys used to be the most common that were used, and certainly my experience when we had loads of trachees on the ward 2 years ago, everybody had a Shiley in, but they generally have the smaller size. So she has a 3.5 and she'll have a size 3 Shiley in her box that you use for an emergency. They have to be changed every week, and you just throw them out. You don't cut sterilise them or clean them. They are generally slightly more. That one looks like a dirty one. So overall, you just have to minimise the risk of blockage, minimise the risk of decannulation, and be prepared for emergencies. So a lot of that is kind of a nursing, kind of what they would be doing generally when they're looking after some of the trachea. But it's always good if you're on the ward and she has been having issues, that you kind of know where all the emergency stuff is. One of the key principles, and they've learned a lot about this with trachees over the years, is that you still need humidity. If you're breathing through a trachea, you're kind of bypassing the upper airway. So most of them, and I would say again before, nobody had a wet circuit outside of ICU. Now everybody has a wet circuit. Very difficult for the families because you can't move that heater. It's not portable. It's not battery usable. So they're kind of stuck. So they generally have humidity at night and then just have a dry circuit during the day. That's if you're on ventilation. If you're not on ventilation, then you would use these HMEs, which is just heat moisture exchange. There's lots of different variations of them, and currently Ali has one similar to this, this one, but she gets oxygen through it as well. So she has a Swedish nose HME with an oxygen connected to it. Most of the other ones then used to be this. They love this, you know, you can't have oxygen through it. So there's lots of versions, but generally everybody should have some sort of HME on. And if you need a speaking valve, then it just looks slightly different, but most of them manage that themselves. If you're on a dry circuit or if you're not on any ventilation, you get your nebs in through this wee system, which is just slightly different. Everybody's seen these before, those Air John Solo thing. She does get regular saline nebs, and then Benji, before he did get the Sabutol, I think he got different medications, but it's just a way of administering the neb. So if you see anybody, this little box is attached just to her heater, and she gets her nebs through that. So it's just a way to give extra if they do need nebulizers and stuff. And we learned quickly for her that she needs that regularly. It's not a PRN type of a thing. You can't just leave it if she seems okay, just to keep on top of it, because she does block her trachea quite easily. Has anybody ever changed a trachea? Ever been ICU? So it's changing the trachea and changing the tapes are the two biggest things, and that's what the nurses would generally be kind of nervous around doing. Tapes are changed every day. They're just used to secure the trachea. It's difficult. It's a really footery job. So if you were ever involved in an emergency, you would kind of have to be able to do the tapes, or else be able to hold to be able to do them. The basic principles are it's tied around their neck, not too tight and not too loose, and you have to have 3 knots to set to secure at the end. That sounds really easy, just saying that 2 sentences, but it is tough. It's tricky, and she has had emergency trachea changes when she's been with us, so just be mindful of it. The only other thing about when you're doing tapes or anybody, just make sure there's no gauze or cotton wool or anything that can fleck inside the trachea, whenever you're doing it, if they're cleaning it or doing it. Changing the trachea then, and Ruth likes that wee person. I don't really like him. I didn't want to tell you that. It makes me sad because I don't like that movie. I'm going to take him out. I've decided. Changing the trachea, if the nurses were doing it on the ward and they got stuck or anything, they're going to call you into when it's an absolute disaster. All their training says call for for expert help quickly. So usually the experts. So if they don't get a trachea in, if it's blocked or if it's fallen out, they're going to be shouting for help, because they did find, and a lot of the research showed, mostly in adults, nurses especially, just seem to work with people with tracheas and not declare an emergency when they don't really have an airway, where they would call an emergency quicker if they didn't have a trachea. So that's kind of the training that we do. Everybody's trained to do an emergency trachea change, and if it's blocked and they need to change it, they will just do it, but they might call you in between that to make sure that there's somebody on hand to do it. But we'll kind of go through it briefly. Suction, if you've came from any other area, it might be slightly different. So this is what the majority of our suction machines look like in Northern Trust. Some of them are slightly different. They have a flip on-off button. Some of them don't. Some of them just turn the dial. So just be mindful that you know how to do suction if she was really sick. And if you're in community, or if they were in the canteen, they would be using the portable suction, which sounds like a helicopter. It's so loud. I hate it. I can't stand the noise of it. The main things you need to know about suction, if you're ever going to suction somebody out from a trachea, is know why they have a trachea, why you're sucking them out, what size of catheter you use, what depth you go to. You don't really want to go deeper than what the trachea is. And her measurement is 9. If she doesn't have her Swedish nose on, it's 9.5 if she does. Know what to turn your pressure to. What you don't want to do is whack up the suction really, really, really high, and you're going to cause trauma. And make sure that it's working. Sometimes if they're trying to suck children out in the dark, if you notice that the canister's full, just tell the nurses they need to change it. And you clean it in between, because obviously those secretions are all just pulling in that tubing. Infection control hate it, any water sitting around. And saline suction can be effective if they do have a mucus plug. People used to get routine saline suction all the time. They don't tend to do that anymore, but that might be something if you think it's blocking, to try and stop an emergency change. But if you think it's blocked, just instigate a change. Just say, I think you need to do that. The nurses will maybe, depends who's on, might resist that a little bit of information, but if it needs change, you just have to do it. Mhm. And also we do have band 3s on the ward who are in the process of being signed up. They have looked after other patients before. They're maybe not totally signed off for Ali at the minute. I think there's maybe just one that's not, but they do the routine, but their plan is escalate early. So, and they can do a change and they can assist. So everybody, yeah, and because we've had so many in a row, actually, there's quite a few people that are quite, it's not like the ports where we're kind of like, we're not really sure. Trackies would be, and it really, in Causeway, they did really, really well without having a trachea ever, and then to have a trachea vented, who was actually cardiac, whose stats were 75 normally on a ventilator, was challenging, but he's home and thriving, and they did really well. So most of the children in patients will have bedhead signs with all of their information. And if they have a new trachea, there has on occasion, very rarely, a new trachea has been cited here for some of the older children from ENT here. And there's been a couple of tonsillectomies that have gone badly here and they've needed tracheaed. Generally they would end up in PICU, but we did have a good few years ago that came down to the ward, and the ENT consultant was like, okay, Lisa, you're going to change the trachea. And I was like, no, I think you need to do that the first time. So there may potentially be a new one, but hopefully never, touch wood, again. She just has a routine trachea sign up on her bed, and she has her airway, who I don't know whether it's Gary Doherty, she has a whole detailed thing about the problems with her airway because she is difficult. So all of those details should be on it. So you should be able to know that if you go into her room and you see that. And then they all have the emergency escalation as well, either inside their box or, but we'll go through that kind of what you do if it kind of doesn't, if it doesn't go in. On this slide, which lasts me every single time, is my favourite slide that I think I've found in my whole children's nursing career. And it's something that we try and teach the nurses and the band 3s, that no matter what you're going in to be called into, that there is still a child sitting in the middle of it, and they are very frightened, probably traumatized because they've had a trachea. And certainly that wee boy who's 14 at home, he needs psychology. Like, he is so traumatized. Every trachea change every month is a whole, he is so upset by it, and that's just because he had been so sick for so long, and people have just gone in and treated the problem and not kind of thought of him in the kind of center of it all. So they all have a lot of equipment around them, and they are well alert children who are probably just playing 2 minutes before if something has happened suddenly. They're not the sedated, ventilated children from PICU, and that's what we're trying to, whenever they're going home, we're trying to kind of build up. Most of them are going home to go to school, most of them are going home to live in busy family lives, but it's tough because people do panic and they look at the ventilator. And I will say, not so much Ali, but Benji used to regularly just disconnect his ventilator and hold it, you're looking at the ventilator, it's an alarming thing, and what's wrong, and he's sitting playing the drums, and you're like, he's obviously fine. So just look at them first. We learned that kind of, I don't know if anybody's do meet Benji, when he has the wee short arms, he learned to play the drums so early on. He did. He used to sit, and our boss was, whenever he came down, there was a whole thing about getting people signed up in the band 3s. He was like, what's the first thing you do? You meant to check your equipment. And they were like, no, Lisa said you have to speak to Benji. And he was just like, yeah, we speak to him. And then Benji's going like, look at me, playing the drum. So you have to, but some of them are sick and you kind of have to just get on with it. But yeah,